Hey there. Tonight, we're stepping into a world where the cure was often more terrifying than the disease itself. Not the sterile operating rooms and miracle drugs of today, but the grim reality of Victorian medicine, where well-meaning doctors prescribed mercury for melancholy, drained blood until patients collapsed, and operated with knives crusted in the dried remnants of previous surgeries. You won't find miraculous recoveries here, just the cold truth of an era when seeking medical help often meant signing your own death warrant. If these unsettling tales from medical history help you drift into dreams, you can like and subscribe, but only if they truly bring you that strange comfort of knowing things are better now. And if you'd like to help our peaceful historical channel grow, your support means more than you imagine. Tell me in the comments where you're listening from, the time on your clock, and whether you're grateful for modern medicine. It's oddly comforting to know who else is drifting off to these same dark chapters of human progress. So, dim the lights, let the shadows of the past settle around you, and let's begin with an era when doctors killed with confidence. The Victorian Age, spanning from 1837 to 1901, was a time of tremendous progress. Steam engines conquered distance. Telegraph wires connected continents. Grand exhibitions showcased humanity's ingenuity. The British Empire stretched across the globe, and the sun never set on territories marked in red. Progress seemed unstoppable, inevitable. And yet, if you fell ill during this golden age of advancement, your chances of survival might actually decrease if you sought medical attention. This wasn't the Dark Ages. This wasn't medieval superstition. This was the height of the modern era, and medicine was confidently, systematically killing people. When Queen Victoria ascended to the throne, medicine stood at a peculiar crossroads. On one hand, there was growing scientific curiosity, new tools like the stethoscope, and an expanding body of anatomical knowledge. On the other hand, treatment remained rooted in theories dating back thousands of years to ancient Greece and Rome. Doctors trained at prestigious universities, wore fine clothes, and spoke with authority. They prescribed elaborate treatments, performed dramatic interventions, and charged substantial fees. And their patients died. They died in astonishing numbers, often directly from the treatments meant to save them. The gap between medical confidence and medical competence was vast. Physicians believed they understood the body's workings, that they possessed the knowledge to intervene successfully. They wrote learned papers, debated theories, and established professional societies. The medical establishment was becoming increasingly organized, increasingly respected. What it wasn't becoming was more effective. In many ways, the average person was safer avoiding doctors entirely, relying on rest, basic nursing care, and hope. Because the moment you entered a physician's care, you entered a world where the remedies on offer included toxic metals, aggressive blood drainage, and invasive surgeries performed in conditions that would horrify a modern veterinarian. Consider the mathematics of Victorian medical care. In some London hospitals, post-operative mortality rates reached 80%. 80%! That means if you went under the knife, you had a 4 in 5 chance of never waking up properly, of succumbing to shock, blood loss, or the infections that followed like night follows day. Even a 50% mortality rate was considered acceptable, normal, just the cost of doing business. These weren't unusual circumstances or wartime emergencies. This was standard practice in peacetime, in the great hospitals of the world's most powerful empire. The Victorian Age saw tremendous advances, yes. Louis Pasteur's work on microorganisms, Joseph Lister's antiseptic techniques, the gradual acceptance of germ theory. But these breakthroughs came late in the period, and even when they arrived, they met fierce resistance from the medical establishment. For most of Victoria's reign, medicine operated on principles that were not just wrong, but actively harmful. And the confidence with which these treatments were administered made them all the more deadly. Let's be clear about what we're discussing here. We're not talking about the failures of primitive medicine where people did their best with limited knowledge. We're talking about an era where doctors had access to better information, but chose to ignore it, where treatments were continued despite obvious harm because they fit existing theories, where professional pride and economic interests outweighed patient outcomes. This was medicine that killed not through ignorance alone, but through willful blindness and stubborn adherence to tradition. The human cost was staggering. Mothers died in childbirth from puerperal fever, and infections spread by the unwashed hands of the very doctors attending them. Soldiers survived battlefield wounds only to die from the mercury administered for routine infections. Children given teething powders containing calomel suffered mercury poisoning that left them disfigured or dead. The wealthy, who could afford the best medical care, often fared worse than the poor who couldn't afford any treatment at all. Being able to pay for a physician's services might mean paying for your own death warrant. And through it all, the medical profession maintained its authority. Doctors who questioned established practices were ridiculed, dismissed, even driven to madness and death. Ignaz Semmelweis, who proved that hand-washing saved lives, died in an asylum. His contemporaries couldn't accept that they, the learned physicians, might be the vectors of disease. It was easier to believe in mysterious miasmas and imbalanced humors than to accept that their own practices were killing people. Pride, it turned out, was as deadly as any poison in the pharmacy. This is the story of Victorian medicine. Not the triumphal narrative of steady progress, but the darker truth beneath the polished instruments and professional societies. It's the story of treatments that cured nothing and killed plenty, of a medical system so sure of itself that it marched confidently forward even as its patients fell like wheat before a scythe. It's the story of how the very people sworn to heal became, through deadly certainty and resistance to change, agents of harm on a massive scale. So, settle in. Breathe slowly. Let the weight of history rest heavy on your chest, like a Victorian physician's confidence. Because we're about to explore an era when seeking help meant risking everything, when medicine's failure rate would shame a medieval barber, and when the greatest danger often came not from disease, but from the cure. To understand how Victorian medicine became so deadly, we must first understand the theories that guided it. These weren't random superstitions. They were systematic, logical frameworks that had been refined over centuries. The problem was that they were completely wrong, and this wrongness had consequences measured in corpses. At the foundation of Victorian medical practice lay the ancient theory of the four humors. This system, inherited from the Greek physician Hippocrates and elaborated by Galen in the 2nd century, held that the body contained four essential fluids: blood, phlegm, black bile, and yellow bile. Health depended on maintaining the proper balance of these humors. Disease occurred when they became imbalanced. Treatment, therefore, meant restoring balance by adding or removing whatever humor was in excess or deficiency. It sounds logical in an abstract way. The problem was that none of it was true. There is no such thing as black bile. The body doesn't work through balancing invisible fluids. But for over 2,000 years, this theory dominated medical thinking. And in the Victorian era, it still held tremendous sway, especially among older physicians trained in traditional methods. Even as new ideas emerged, many doctors continued to view illness through the lens of humoral imbalance, prescribing treatments designed to shift these imaginary fluids. The theory had a seductive internal consistency. Fever, too much blood. Solution, remove blood. Lethargy, excess phlegm. Solution, induce vomiting or sweating to expel it. Melancholy, black bile accumulation. Solution, purge the bowels with powerful laxatives. Every symptom could be explained within the system, and every explanation led to an intervention. The fact that patients often worsened or died wasn't seen as evidence against the theory, but rather as proof that the imbalance had been too severe, the treatment too late, or the application insufficient. Alongside humoral theory ran another flawed concept, the miasma theory of disease. This held that illnesses arose from bad air, or miasmas, emanating from rotting organic matter, swamps, or crowded urban areas. The theory had some basis in observation. Diseases did seem more common in filthy, crowded places. Swamps did seem unhealthy. The connection drawn, however, was entirely wrong. It wasn't the smell or the bad air causing disease. It was the contaminated water, the poor sanitation, the close quarters allowing infection to spread from person to person. But the miasma theory shaped medical practice in profound ways. Since air was the problem, hospitals would open windows to air out wards at midday, believing this simple ventilation would prevent the spread of infection. Meanwhile, they saw no need to wash hands between patients, no reason to clean instruments, no point in isolating infectious cases. After all, if disease came from bad air, what difference did hand washing make? This misunderstanding killed thousands. Hospitals became death traps, places where infections spread uncontrolled because the very theory guiding their operation was fundamentally mistaken. The resistance to new ideas proved as deadly as the old ones. When, in the 1840s, Hungarian physician Ignaz Semmelweis noticed that maternal mortality dropped dramatically when doctors washed their hands before attending births, he presented his findings with clear statistics. Hand washing reduced death rates from 18% to less than 2% in his clinic. The evidence was overwhelming. The medical establishment's response was rejection, ridicule, and ultimately persecution. Semmelweis was driven from his position, haunted by colleagues who found his implications insulting. How dare he suggest that doctors, gentlemen, and scholars were the source of infection? How dare he prioritize washing over traditional practice? Semmelweis died in an asylum in 1865. His warnings unheeded, his discoveries dismissed. Meanwhile, women continued dying from puerperal fever, an entirely preventable infection spread by the unwashed hands of physicians moving from autopsy room to delivery ward. The medical profession's pride killed more women than any disease. They simply couldn't accept that their practices, refined over generations, might be fundamentally wrong. This resistance wasn't unique to Semmelweis. Any challenge to established theory met fierce opposition. Medical education emphasized tradition, ancient texts, and received wisdom. Students learned what Galen had written 1,600 years earlier, memorized humoral theory, and absorbed the conviction that their training made them authorities beyond question. The idea that a simple intervention like hand washing could be more effective than learned treatments challenged the entire foundation of medical identity. To accept it meant admitting that years of training, all that Latin and theory, all that careful bleeding and purging, had been worse than useless. It had been actively harmful. The medical profession of Victorian England was increasingly organized and hierarchical. At the top sat physicians, university-educated men who read Greek and Latin medical texts and prescribed treatments, but rarely touched patients. They were gentlemen, and their status came partly from this separation from manual labor. Below them were surgeons, who actually performed operations and set bones, but were considered tradesmen rather than scholars. Lower still were apothecaries, who mixed medicines and often served as primary care for common people. This hierarchy reinforced conservative practice. Physicians, by virtue of their classical education, claimed superior knowledge and defended traditional theories most fiercely. Economic interests also played a role. Medicine was becoming professionalized, with licensing laws and professional societies designed to exclude competition and maintain standards. But these standards were often about protecting the profession's status and income rather than patient outcomes. Doctors who charged substantial fees for elaborate treatments had little incentive to admit that simpler, cheaper approaches might work better, or that many conditions would resolve on their own with mere nursing care. The average Victorian seeking medical care entered a system that was organized, confident, and increasingly institutional. What it wasn't was effective. The theories underlying treatment were wrong. The resistance to new ideas was fierce, and the gap between what doctors believed they knew and what actually helped patients grew wider with each passing year. Into this gap fell thousands of lives, lost not to disease, but to the remedies prescribed with such certainty by the men who claimed to heal. This foundation of flawed theory and stubborn tradition set the stage for every deadly treatment that followed. Because if your basic understanding of how the body works is wrong, every intervention you make will likely cause harm. And if you combine that wrong understanding with absolute confidence, professional pride, and resistance to correction, you create a perfect storm of medical catastrophe, which is exactly what Victorian medicine was, a sustained catastrophe, dressed in professional authority and delivered with deadly conviction. Now we turn to one of the most widespread and devastating treatments in the Victorian medical arsenal, mercury. This toxic heavy metal was prescribed for an astonishing array of conditions, administered in various forms, and caused suffering on a scale difficult to comprehend. It was called many things: calomel, blue mass, blue pills, quicksilver. The names varied, but the active ingredient remained the same: mercury, a poison that accumulated in the body, damaged organs, destroyed tissue, and killed slowly and miserably. Mercury's use in medicine stretched back centuries, but it reached its peak during the Victorian era. Doctors prescribed it for syphilis, melancholy, constipation, parasites, teething in infants, typhoid, mumps, and dozens of other conditions. It was seen as a cure-all, a powerful medicine that could restore health through its dramatic effects on the body. And dramatic they were. Mercury caused intense salivation, painful cramping, violent diarrhea, and vomiting. To Victorian doctors, these symptoms proved the medicine was working, purging the body of whatever illness had taken hold. In reality, these were signs of poisoning, evidence that the patient was being slowly destroyed from within. The most common form was calomel, mercurous chloride, a white powder that could be mixed with sweet substances to make it palatable, or pressed into pills. Calomel was everywhere. You could buy it over the counter at any pharmacy. Doctors prescribed it routinely. Parents gave it to children for the slightest ailment. It was marketed as safe, effective, and essential. What it actually was poison, administered in doses that varied wildly because there was no standardization, no way to know how much mercury each pill contained. Some patients received small amounts that caused manageable symptoms. Others received massive doses that destroyed their bodies. The effects of mercury poisoning were horrific. Early symptoms included excessive salivation, sometimes producing several pints of saliva per day. Patients drooled constantly, their mouths always wet, their chins perpetually damp. Then came the tremors, starting in the hands and spreading throughout the body. These shakes could become so severe that patients couldn't hold utensils, couldn't write, couldn't perform basic tasks. Insomnia plagued them. Their teeth began to loosen and fall out. Their gums would swell, bleed, and eventually rot away, a condition called gingivitis that exposed the bones beneath. But it got worse. The tissue in the mouth would necrotize, turning black and sloughing off. Some patients developed gangrenous holes in their cheeks, exposing their tongue and jawbones. The bones themselves could rot, requiring surgical removal that left faces permanently disfigured. Imagine looking in a mirror and seeing your own jawbone through a hole in your cheek, seeing your tongue through another opening, watching your face literally fall apart. This was the reality for many who took mercury as medicine. The psychological effects were equally devastating. Mercury attacked the nervous system, causing what was called mercurial erythricism, a condition characterized by depression, anxiety, pathological shyness, memory loss, and personality changes. Patients became irritable, paranoid, and socially withdrawn. They experienced hallucinations, lost cognitive function, and sometimes descended into complete psychosis. The phrase "mad as a hatter" entered common usage because hat makers, who used mercury in the felting process, frequently developed these psychiatric symptoms. But hatters weren't the only victims. Anyone taking mercury as medicine faced the same neurological devastation. The medical profession observed all these effects and continued prescribing mercury. Why? Partly because the symptoms fit humoral theory. Mercury made patients salivate, sweat, vomit, and purge their bowels, all actions thought to rebalance the humors. The more dramatic the effect, the more effective the treatment seemed. That patients often died was attributed to the severity of their original illness, not to the medicine itself. That they developed horrible new symptoms was sometimes dismissed as unrelated conditions, not consequences of treatment. Consider the case of Elizabeth Story, a Scottish seamstress who wrote her autobiography in 1859. As a child, she had some mild illness that prompted her doctor to treat her with prolonged administration of calomel. The mercury poisoning that resulted left her severely disabled for life. Her hands and feet swelled, her skin peeled off, her flesh literally separated from her body like tomatoes in boiling water. She lost weight, clawed at herself from intense itching, suffered fevers, and exhibited symptoms that her mother described as insanity in a child, banging her head, screaming, scratching anyone who approached. Elizabeth survived, but her life was defined by the disability caused not by her original illness, but by the medicine that was supposed to cure it. During the American Civil War, soldiers were routinely given calomel for various ailments. In 1862, a soldier named Carlton Bergen was treated with calomel for an infection. The mercury poisoning left him permanently disfigured, his face destroyed by the very treatment meant to help him. How many other soldiers suffered similar fates? Records don't tell us, but given the widespread use of calomel in military medicine, the number must have been substantial. Men who survived bullets and disease were destroyed by their own doctors. Famous figures weren't spared. Abraham Lincoln took blue mass pills for years before his presidency, likely for melancholy and general ailments. These pills contained significant amounts of mercury. During this period, Lincoln exhibited symptoms consistent with mercury poisoning, insomnia, tremors, and rage attacks. He reportedly stopped taking the pills a few months after his inauguration because he perceived they made him cross. A typical daily dose of blue mass pills represented ingestion of more than 100 times the daily limits set by modern environmental safety standards. Lincoln was essentially poisoning himself on his doctor's orders. Edgar Allan Poe, 3 months before his death in a delirious state, had been treated with calomel pills after exposure to cholera. High levels of mercury were later found in samples of his hair. Whether the mercury contributed to his final breakdown remains debated, but it certainly didn't help. Louisa May Alcott, the author of Little Women, contracted typhoid in 1863 while serving as a Civil War nurse. She was treated with calomel and never fully recovered, suffering from skin rashes, musculoskeletal pain, gastrointestinal problems, and headaches for the rest of her life. She died in 1888, believing her affliction was due to mercury poisoning. Modern medical analyses have debated this, but her own perception was that the cure had been worse than the disease. Mercury was also used for syphilis, and here its popularity reached truly grotesque heights. Syphilis was a scourge in Victorian times, and mercury was the standard treatment, administered as ointments, pills, injections, vapor baths, and even douches. Patients would rub mercury ointment into their skin, breathe mercury vapor, or have mercury compounds injected directly into their bodies. A famous saying captured the reality: "A night with Venus and a lifetime with Mercury." The treatment lasted years and was excruciating. Patients suffered all the horrible effects of mercury poisoning, while the syphilis itself often continued to progress. The medical rationale was that mercury killed the syphilis spirochete. In high enough concentrations, it might have had some effect, but those concentrations also killed the patient. The trade-off was brutal. You might suppress the syphilis temporarily, but you'd suffer mercury poisoning permanently. Some patients chose to stop treatment, declaring that the medicine was making them sicker than the disease. They were right. But their voices were often drowned out by medical authorities who insisted that mercury was necessary, that the suffering was part of the cure, that to stop treatment meant certain death from syphilis. Women suffered particularly from mercury treatments. When mercury compounds were used as vaginal douches for venereal diseases, the results were catastrophic. The mercury absorbed through vaginal tissue, causing acute poisoning. An 1891 article in the Journal of the American Medical Association documented a woman who doused with mercury chloride and experienced 4 days of persistent vomiting before seeking medical care. Over the next several days, she vomited blood, fell into a stupor, developed kidney failure, and died within a week. The physician who documented the case wrote that the absorption of poison in toxic quantities through the vagina should constitute a warning to doctors that mercury could hardly be employed safely in this manner. But that didn't stop doctors from continuing to prescribe it. The use of mercury in children's medicines was particularly unconscionable. Teething powders containing calomel were sold until 1948. These caused a condition called pink disease in babies. Icy, swollen, red, and intensely itchy hands and feet that would peel like blanched tomatoes. Babies who received these powders would lose weight, cry inconsolably, claw at themselves until their skin was raw, develop fevers, and exhibit symptoms of insanity. Some died. Others survived with permanent damage. And all the while, the powders were marketed as safe and necessary for teething, something every good parent should use. The medical profession observed all this suffering and death and continued to prescribe mercury. Some doctors began to question the practice in the mid-1800s. Some published papers documenting the harmful effects. Some tried to spread the word that mercury was poisoning patients. But change came slowly, agonizingly slowly. Mercury compounds remained in common medical use well into the 20th century. It wasn't until after World War II that mercury was finally removed from most medicines, and even then, not because of sudden realization of its dangers, but because better alternatives had been developed, and because the accumulating evidence could no longer be ignored. Looking back, the mercury era of medicine stands as one of the darkest chapters in medical history. Here was a treatment that was obviously poisonous, that caused horrific symptoms, that killed and maimed on a massive scale, and that the medical profession defended for centuries. It was prescribed for everything, sold to everyone, and questioned by almost no one in authority. The confidence with which Victorian doctors administered mercury matched the certainty of its harmful effects. For every patient who might have received marginal benefit, hundreds suffered needlessly, their bodies destroyed by a metal that should never have been considered medicine. Tonight, as you drift toward sleep, consider this. The same doctors who prescribed mercury wore fine clothes, read learned journals, and belonged to prestigious medical societies. They weren't ignorant villagers relying on superstition. They were educated professionals operating within a system that valued tradition over evidence, authority over observation, and professional pride over patient outcomes. They prescribed mercury not despite knowing it was harmful, but because they believed so firmly in their own knowledge that they couldn't see the truth even as it poisoned their patients before their eyes. That confidence, that deadly certainty, killed more surely than the mercury itself. If mercury was the slow poison of Victorian medicine, bloodletting was its dramatic killer. For thousands of years, the practice of draining blood from patients was considered one of the most important therapeutic interventions a physician could perform. By the Victorian era, bloodletting had evolved into what was called heroic medicine, an aggressive approach that involved draining massive quantities of blood in the belief that this would shock the body back to health. Instead, it shocked patients into weakness, collapse, and often death. The theory behind bloodletting made sense within the framework of humoral medicine. Blood was one of the four humors, and many illnesses were attributed to plethora, an excess of blood. Fever, too much blood heating the body. Inflammation, blood rushing to the affected area. Apoplexy, blood overwhelming the brain. The solution seemed obvious. Remove the excess blood, and the body would return to balance. It was logical, systematic, and completely wrong. But logic mattered little when tradition held such power. Bloodletting had been practiced since ancient times. Galen, the Roman physician whose writings dominated medical thinking for 15 centuries, had been a strong advocate. If Galen recommended it, if it had been done for millennia, if every medical text and every professor taught its importance, how could it be wrong? This weight of tradition made bloodletting nearly unquestionable within the medical profession. To doubt it was to doubt the entire edifice of medical knowledge. The methods varied. The most common was venesection, opening a vein with a lancet and allowing blood to flow freely into a bowl. Physicians would carefully choose which vein to open based on the location of the illness, following ancient diagrams that mapped specific veins to specific organs. They would watch the blood flow, noting its color and consistency, reading meaning into qualities that had no diagnostic value. A pint might be drawn, or two, or more, depending on the physician's assessment and the patient's condition. Leeches offered another method, particularly popular in Victorian times. These segmented worms, raised in special farms, were applied to the skin where they would attach with their three-part jaws and begin feeding. A single leech could consume several times its body weight in blood before detaching, sated. Physicians would apply dozens at once, covering afflicted areas with the writhing creatures, waiting for them to drain the supposedly harmful excess. The marks they left behind, the circular wounds that bled freely even after the leeches were removed, were considered evidence of successful treatment. Cupping provided yet another approach. Glass cups would be heated and placed on the skin. As the air inside cooled, it created suction, drawing blood to the surface and sometimes breaking capillaries. In wet cupping, the skin would first be scarified, tiny cuts made before applying the cups, so that blood would pool into them. The resulting bruises and blood accumulation were thought to draw out disease. All these methods had one thing in common: they weakened patients. Blood is essential for life. It carries oxygen, nutrients, immune cells, everything the body needs to function and fight disease. Removing it in large quantities doesn't restore balance. It creates shock, weakness, and vulnerability. A patient already weakened by illness would become more so. Their heart would race, trying to compensate for lost volume. Their blood pressure would drop. Their organs would struggle with reduced oxygen supply. And their immune system, already fighting infection, would be deprived of the cells needed to mount an effective defense. Yet the practice continued, and in the late 1700s, it intensified into what became known as heroic medicine or heroic depletion therapy. The driving force behind this approach in America was Benjamin Rush, a physician and founding father who signed the Declaration of Independence. Rush believed that most diseases arose from overstimulation of the blood vessels, and that aggressive bloodletting combined with powerful purges would cure almost anything. He advocated draining enormous quantities of blood, up to 80% of a patient's total volume, while simultaneously administering massive doses of mercury to induce vomiting and diarrhea. When yellow fever struck Philadelphia in 1793, Rush put his theories into practice with evangelical fervor. As other physicians fled the epidemic, Rush remained, treating hundreds with his heroic methods. He would bleed patients until they fainted, then bleed them again. He administered calomel in doses large enough to cause acute mercury poisoning, viewing the resulting symptoms as evidence of efficacy. The combination of blood loss and mercury poisoning devastated already weak patients. Many died directly from the treatment. Rush recorded his successes, noting those who recovered, but seemed unable or unwilling to acknowledge how many he killed. The death of George Washington illustrated heroic medicine at its deadly worst. When the former president developed a throat infection, probably acute epiglottitis, his physicians responded with aggressive bloodletting. They drained approximately half his blood volume in less than 12 hours. They also administered calomel, applied blistering agents to raise welts on the skin, and induced vomiting. Washington, who had survived warfare and the trials of founding a nation, could not survive his doctors. He died, almost certainly hastened to death by the very treatments meant to save him. His physicians, rather than questioning their methods, concluded that they hadn't been aggressive enough, that they should have bled him more. This exemplifies the fundamental problem with heroic medicine. It created a self-reinforcing belief system. If a patient recovered, the treatment worked. If they died, they hadn't received enough treatment. The possibility that the treatment itself was harmful couldn't penetrate this circular logic. And because the treatments were so dramatic, producing such obvious effects, practitioners felt they were doing something, taking decisive action against disease. The alternative, providing supportive care and allowing the body to heal itself, seemed passive, defeatist, not worthy of a physician's skill and training. The actual effects of bloodletting were entirely predictable. Patients lost consciousness not because their excess blood was being balanced, but because their blood pressure dropped precipitously. They became pale and weak not from the disease leaving their bodies, but from the oxygen-carrying capacity of their blood being reduced. They felt cold because their circulatory system was failing. They died because you cannot drain a human being of their blood and expect them to survive, especially when they're already fighting illness. Some illnesses were treated more aggressively than others. Fever, inflammation, and plethoric conditions received the most bloodletting. But the logic expanded until nearly any condition could justify it. Melancholy? Bleed them to reduce the blood's oppressive weight on the mind. Headache? Bleed them to reduce pressure. Infection? Bleed them to remove corrupted blood. The indications multiplied, and with them the death toll. Military medicine adopted heroic methods enthusiastically. Soldiers in the 1800s faced not only enemy weapons, but also their own medical corps. A wounded soldier might have survived his injury only to be bled into weakness by the surgeons treating him. Camp diseases like dysentery and typhoid were treated with bloodletting that hastened death rather than preventing it. The logic seemed impeccable to military physicians. Soldiers needed to be returned to duty quickly. Aggressive treatment seemed like taking decisive action, and if they died, well, battlefield medicine was necessarily rough. The poor and working class, paradoxically, often fared better than the wealthy when it came to bloodletting. They couldn't afford repeated physician visits, couldn't pay for extensive treatments. When they fell ill, they might see a physician once, if at all, receive perhaps one bloodletting, and then convalesce at home with basic nursing care. The wealthy, who could afford the best medical attention, received it in full measure. Repeated bleedings, aggressive dosing, constant physician attendance. Their superior access to health care often meant superior access to harmful interventions. Women faced particular dangers from bloodletting. Childbirth complications, puerperal fever, and hysteria all became indications for aggressive blood drainage. A woman already weakened from delivery would be further weakened by therapeutic bloodletting. If she developed infection afterward, she would be bled again, her body's ability to fight the infection deliberately undermined. The maternal mortality rate in hospitals was higher than in home births, partly because hospital births meant more medical intervention, including bloodletting, performed by physicians who carried infection from patient to patient on their unwashed hands while simultaneously draining them of the blood needed to fight those infections. By the mid-1800s, opposition to heroic bloodletting was growing. Some physicians began publishing statistics showing that patients who received less aggressive treatment actually fared better. Homeopaths, whose practice emphasized gentle remedies and the body's natural healing capacity, gained followers partly because their treatments didn't actively harm patients. When a homeopath's survival rates exceeded those of conventional physicians practicing heroic medicine, people noticed. They might not understand why the difference existed, but they could count the survivors. The medical establishment resisted these challenges fiercely. Physicians who advocated less aggressive approaches were accused of timidity, of lacking the courage to take bold action against disease. Medical schools continued teaching bloodletting as essential. Textbooks continued recommending it. The weight of tradition and professional identity was too heavy to shift quickly. Change came gradually, reluctantly, as younger physicians trained in newer methods slowly replaced older practitioners wedded to heroic approaches. By the latter part of Victoria's reign, bloodletting was declining but hadn't disappeared. Leeches were still sold, lancets still carried. Some physicians continued the practice until the end of their careers, unable or unwilling to abandon what they'd spent their professional lives doing. The theoretical justification might have weakened, but habit and training kept hands reaching for the lancet. The legacy of bloodletting is a stark reminder of how confidence can be lethal. For centuries, learned physicians drained the life from their patients while believing firmly that they were restoring health. The practice survived not because it worked, but because it was traditional, because it aligned with accepted theory, because admitting it was harmful would have required admitting that generations of physicians had been wrong, that countless patients had been killed by the very people sworn to heal them. That admission was too difficult, the professional pride too great, and so the bloodletting continued, and the patients died, and the physicians moved on to the next patient with their lancets sharp and their confidence unshaken. If you could travel back to a Victorian operating theater, the sight would stop you cold. Not with admiration or the thrill of witnessing medical progress, but with revulsion and horror. The room would be dingy, poorly lit, thick with spectators who had purchased tickets to watch the spectacle. The operating table would be wooden, stained dark with the blood of countless previous patients, never properly cleaned between uses. The surgeon would approach wearing not sterile whites, but a frock coat encrusted with dried blood and bodily fluids, worn like a badge of experience. His instruments would be similarly stained, cleaned perhaps with a cursory wipe, but never sterilized because the very concept didn't exist. And the patient, if they were conscious, would be held down by strong assistants, about to endure the most horrific experience of their life. This was surgery in the Victorian era, and it killed with ruthless efficiency. In some hospitals, the post-operative mortality rate reached 80%. 8 out of 10 patients died. In others, a 50% mortality rate was considered acceptable, normal, just part of the process. These weren't unusual statistics or wartime emergency conditions. This was everyday surgical practice, in peacetime, in major hospitals, in the heart of the world's most advanced civilization. Before the introduction of anesthesia in the 1840s, surgery was as much about speed as skill. A patient's agony could only be endured for so long. Shock from pain could kill just as surely as the underlying condition. Surgeons prided themselves on their quickness. Robert Liston, one of the most famous surgeons of his time, could amputate a leg in under 3 minutes. His speed was legendary, his confidence absolute. Unfortunately, his most famous operation achieved something unique in medical history, a 300% mortality rate. The surgery was a routine leg amputation. Liston worked with his characteristic speed, his blade flashing as spectators watched from the surrounding seats. In his haste, he accidentally cut off his assistant's fingers. Both patient and assistant later died of gangrene, the infection that followed dirty surgery like night follows day. But there was a third casualty. A spectator, watching the bloody scene unfold, was splashed when Liston's knife sliced through an innocent bystander's coat. The spectator, believing himself wounded, apparently died of shock on the spot. 3 people died as a result of one operation. It was exceptional, certainly, but it illustrated perfectly the casual brutality of pre-antiseptic surgery. Speed was necessary because patients were conscious. Imagine it. You're suffering from a diseased leg, the pain excruciating, the smell of gangrenous tissue filling your nostrils. You're told the leg must come off. There's no anesthesia, no way to escape the awareness of what's about to happen. You're tied to a wooden table or held down by several strong men. The surgeon appears with his saw and knives. Then he begins cutting into your flesh, your nerves screaming, every fiber of your being focused on the agony as bone is exposed and sawed through, as arteries are tied off, as your own leg is removed from your body while you watch and feel and scream. The trauma was so severe that some patients died on the table from shock alone, their hearts simply stopping from the overwhelming pain. The introduction of ether and chloroform in the 1840s should have revolutionized surgery. Finally, patients could be rendered unconscious, spared the torture of feeling every cut. Surgeons could take their time, work more precisely, perform more complex operations. And initially, this seemed like pure progress. But a strange thing happened. Mortality rates actually increased. Surgery became more deadly with anesthesia than it had been without. Why? Because anesthesia removed the one natural brake on surgical ambition, the patient's ability to endure pain. Before anesthesia, the agony limited how long and how deep a surgeon could go. With unconscious patients, surgeons began attempting more invasive procedures, going deeper into the body, spending more time with the patient open on the table. And because they still didn't understand infection, because they still didn't wash their hands or instruments, because they still operated in filthy conditions, these longer, more invasive surgeries exposed patients to even more contamination. The operating table became, as one historian described it, a conveyor belt. One patient after another would be operated on without the table being cleaned, without instruments being washed, without any understanding that each operation was spreading infection from patient to patient. The surgeon's blood-crusted coat, which he wore with pride, was essentially a culture medium for deadly bacteria. His unwashed hands were vectors of disease. His instruments, stored in cases lined with old velvet or leather, were contaminated with the remains of previous patients. And into this toxic environment, he would cut deep into unconscious patients who couldn't protest, couldn't resist, couldn't do anything but lie there while their bodies were invaded by both steel and microscopic killers. The conditions in operating theaters beggar belief. Floors were covered with sawdust to absorb blood. This sawdust would be swept out occasionally, but was never properly cleaned, instead being saturated with the blood and fluids of dozens of operations. The air was thick with spectators, some medical students, but others just curious members of the public who had paid for tickets to watch the life and death drama unfold. They would crowd in, bringing with them the dirt and germs of the street, breathing and coughing and talking as surgery proceeded below them. The concept of a sterile environment simply didn't exist. The concept of hygiene barely registered. Amputation was the most common operation, usually performed for injuries or infections that had progressed too far. The mortality rate for lower limb amputations could reach 70%. 7 out of 10 patients who had their leg removed would die afterward, usually from infection. Upper limb amputations were somewhat safer, with only 22% mortality, though only seems a grotesque word for death rates that would be considered catastrophic today. These weren't deaths from surgical error, from cutting the wrong artery or severing the wrong nerve. These were deaths from infection that inevitably followed surgery performed in filthy conditions. The infections had names: pyemia, a blood infection that caused abscesses throughout the body; hospital gangrene, a flesh-eating condition that could consume an entire limb; erysipelas, a skin infection that spread with frightening speed; septicemia, blood poisoning that caused fever, delirium, and death. Collectively, these were called hospitalism, a catch-all term for the various infections that ravaged surgical patients. The medical profession knew about hospitalism. They could see patients developing these infections with grim regularity. What they couldn't see, or refused to see, was that they were the cause. The miasma theory was partly to blame. If infections came from bad air, then proper ventilation should prevent them. Hospitals would open windows, air out wards, and consider the problem solved. Meanwhile, the actual source of infection, contaminated hands and instruments, went unaddressed. Surgeons would move from patient to patient, from autopsy to surgery, without washing. The idea that invisible organisms could be transferred on their hands seemed absurd. They were gentlemen, scholars, members of the medical profession. How could they be vectors of disease? Even medical students weren't safe. Between 1843 and 1859, 41 young doctors in training died after contracting infections at St. Bartholomew's Hospital in London. These were healthy young men, presumably with robust immune systems, yet they died from the very environment where they were learning to heal. They would cut themselves on contaminated instruments, develop small wounds during dissections, or simply absorb enough bacterial load from constant exposure that their bodies couldn't fight it off. The death toll among students was accepted as tragic but inevitable, part of the dangerous business of learning surgery. The dissection rooms where students learned anatomy were nightmarish. Unlike modern facilities, students couldn't escape the dead during their studies. They often lived in rooms adjacent to where bodies were stored and dissected. The smell of decomposition was constant. Students would have shreds of flesh, organs, and brain matter stuck to their clothes after lessons. They became so desensitized that they would pull pranks with body parts, have mock sword fights with limbs, smuggle intestines out to scare people. Rats gnawed on vertebrae, sparrows pecked at lung tissue. The French composer Hector Berlioz, briefly a medical student, described it as a vision from hell. And from these rooms, students would go directly to hospital wards, their clothes and hands contaminated, ready to attend living patients. Some surgeons tried desperate innovations. One, faced with a woman whose windpipe was blocked with blood and pus, enlarged the wound in her neck, and then, when instruments failed to clear the passage, simply clamped his mouth over the wound and sucked out the blockage. It saved her life that time, but the fact that such a method was necessary reveals the desperate improvisation that characterized much of Victorian surgery. When cutting and draining didn't work, surgeons would try anything, guided more by immediate necessity than understanding. Speed remained important even with anesthesia because surgeons recognized, however dimly, that longer operations meant more danger. They didn't understand that this danger came from contamination, but they observed that patients who spent less time on the table fared slightly better. So they continued to work quickly, which led to errors. Liston once amputated a leg so quickly that he also removed his patient's testicle. On another occasion, he cut off the patient's leg, 3 of his assistant's fingers, and slashed a bystander's coat in a single operation. These weren't just amusing anecdotes from a colorful character. They were symptoms of a system that valued speed over care, that operated in such dangerous conditions that even the most skilled surgeon became a source of harm. For patients, the decision to undergo surgery was agonizing in every sense. The operation itself might be excruciating if anesthesia failed or wasn't available. Even if they survived the surgery, they faced weeks or months of recovery, during which infection could strike at any time. They would lie in hospital beds, in wards packed with other patients, breathing the same air, attended by the same nurses and doctors, waiting to see if fever would come. When it did, and it usually did, there was little to be done. The patient would be bled, perhaps, or purged, treatments that only weakened them further. They would be watched as their surgical wound became inflamed, filled with pus, and began to rot. They would feel their strength ebbing, their temperature rising, their consciousness fading. And then they would die. Another addition to the grim statistics that everyone acknowledged, but no one seemed able to change. The wealthy often fared worse than the poor when it came to surgery. The poor, if they had surgery at all, received it in charity wards or at home. The conditions weren't good, but at least at home, they weren't exposed to the concentrated infectious environment of hospital surgical wards. The wealthy, who could afford the best surgeons in the finest hospitals, paid for the privilege of being operated on in the most contaminated environments, surrounded by the most infected patients, tended by doctors who had just come from autopsy rooms or other surgeries without washing their hands. Superior access to medical care meant superior access to deadly infection. This was the reality of Victorian surgery, not the gleaming instruments and careful precision of modern operating rooms, but filthy theaters where death was expected, infection was common, and the very people performing the operations couldn't understand why their patients kept dying despite their best efforts. The confidence with which surgeons operated, the pride they took in their bloody coats, the tradition they upheld, all of it combined to create a killing floor where medicine's promise to heal was betrayed with every cut of the knife. The introduction of antiseptic technique by Joseph Lister in the 1860s would eventually change everything, but even that took decades to gain acceptance. Meanwhile, surgery continued in its deadly way. Patients continued dying at appalling rates, and surgeons continued to believe that they were providing the best care possible. The gap between belief and reality, between medical confidence and actual outcomes, was never wider or more lethal than in the Victorian operating theater. In an era when many treatments actively harmed patients, you might think hospitals would at least serve as refuges of healing, places where the sick could recover under professional care. You would be tragically wrong. Victorian hospitals were death traps, institutions where your chances of dying actually increased the moment you walked through their doors. The irony was bitter. The very places dedicated to healing had become epicenters of disease, architectural monuments to medical failure. The statistics were damning. In some London hospitals, mortality rates for surgical patients reached 80%. For women who gave birth in hospitals, death rates from puerperal fever ranged from 10 to 30% or higher. In comparison, women who gave birth at home, attended only by midwives, had much lower mortality rates. The difference was stark and should have been illuminating. Hospitals were killing women. Yet the medical profession continued to promote hospital births, to establish lying in hospitals for mothers, and to send women to the very places that would most likely result in their deaths. The problem was infection, though doctors didn't understand this for most of the Victorian era. They saw patients develop fevers and infections after surgery or childbirth, watched them deteriorate into delirium and death, and couldn't comprehend why. The answer was literally on their hands. Physicians would move from patient to patient, from autopsy room to delivery ward, from surgery to examinations, without washing. Their hands carried bacteria, viruses, and other pathogens from the sick to the healthy, from the dead to the living. Every patient they touched became a potential victim of whatever they'd touched before. Hospital gangrene was particularly feared. This infection would begin in a surgical wound and spread with horrifying speed, consuming flesh, exposing bone, resisting all treatment. Once it started in a ward, it would often spread to other patients, racing through the hospital like wildfire. Patients who had survived their initial operations would see their wounds suddenly inflamed, watch as the tissue around their stitches turned dark and began to rot, and know that death was likely coming. There was no effective treatment. Amputation of the affected limb might stop the spread, but if you'd already had a leg amputated and gangrene set in, what more could be removed? Some surgeons tried cauterizing wounds with red-hot iron, burning away the infected tissue. The agony was extreme and the success rate minimal. Erysipelas, another common hospital infection, attacked the skin. It would appear as angry red patches that spread across the body, accompanied by high fever and systemic illness. Like hospital gangrene, it often moved from patient to patient within wards, suggesting contagion that doctors attributed to bad air rather than direct contact. The treatment was, predictably, bloodletting and purges, interventions that weakened patients when they most needed strength. Pyemia, blood poisoning, was a death sentence. Once bacteria entered the bloodstream, they would spread throughout the body, causing abscesses in organs and tissues. Patients would develop multiple sites of infection, fever spiking and falling erratically, consciousness fading. Nothing could be done. Doctors would watch helplessly as their patients die from an enemy they couldn't see and didn't understand. The architecture of hospitals contributed to the problem. Wards were long rooms packed with beds, patients crowded together with minimal space between them. Ventilation was poor, lighting was dim, privacy was not existent. Patients with infectious diseases lay next to surgical patients, next to women in labor, next to anyone else who needed a bed. Cross-contamination was inevitable. Add to this the complete absence of hygiene protocols, nurses and doctors moving freely between all these patients, and you have perfect conditions for epidemic spread within the supposedly healing environment. Some hospitals required patients to pay a burial deposit upon admission. This wasn't cruel humor, but practical necessity. So many patients died that the hospital needed funds to dispose of bodies. Imagine being sick, going to a hospital for treatment, and being asked to pay for your own burial before they'd even try to help you. The message was clear. The hospital expected you to die, and often their expectations were met. The case of puerperal fever, also called childbed fever, particularly illustrates the deadly nature of hospital medicine. Women who gave birth in hospitals died at much higher rates than those who delivered at home. The reason was physician-transmitted infection. Doctors would perform autopsies on women who had died of puerperal fever, then go directly to attend laboring women, their hands still contaminated. They would perform vaginal examinations on multiple women in succession, never washing between patients, transferring infection from the sick to the healthy, from the dead to the living. Ignaz Semmelweis documented this with devastating clarity in Vienna in the 1840s. He noticed that maternal mortality in the wards staffed by doctors was much higher than in the wards staffed by midwives. The difference was that doctors performed autopsies, while midwives did not. When Semmelweis instituted a policy requiring doctors to wash their hands in chlorinated lime solution before attending births, mortality dropped from 18% to less than 2%. The evidence was overwhelming. The solution was simple, and the medical establishment rejected it completely. Why? Because Semmelweis's findings implied that doctors themselves were causing deaths, that their learned hands were vectors of disease, that their prestigious medical education hadn't taught them the most basic principle of healthcare: clean hands save lives. The implication was insulting to physicians who saw themselves as gentlemen and scholars, not as sources of contamination. Semmelweis was ridiculed, persecuted, and eventually driven from his position. He continued advocating for hand washing, became increasingly bitter and erratic, and ended his life in an asylum, dying from an infection he likely contracted from a wound sustained during his confinement. His warnings went unheeded, and women continued dying from puerperal fever spread by the very doctors attending them. The introduction of anesthesia, which should have made surgery safer, actually made hospitals more dangerous initially. With patients unconscious, surgeons performed longer, more invasive operations, going deeper into the body, spending more time with wounds open and exposed. Since they still didn't understand infection, since they still didn't clean instruments or wash hands, these extended procedures meant more time for contamination, more opportunity for bacteria to invade the body. Post-operative infection rates soared. Hospitals became even deadlier just as surgical capability expanded. Hospital wards were attended by nurses who, before the reforms initiated by Florence Nightingale, received little training and less pay. Many were essentially domestic servants assigned to medical tasks. They emptied chamber pots, changed bloody linens, fed patients, and occasionally administered medicines, all without understanding hygiene or disease transmission. They would move from caring for infected patients to preparing food, from handling soiled bedding to dressing wounds, spreading contamination with every action. The few dedicated nurses who tried to maintain cleanliness fought a losing battle against institutional indifference and inadequate resources. The smell in hospital wards was legendary. Decay, excrement, blood, and infection created a miasma that assaulted visitors the moment they entered. Victorian doctors, believing in miasma theory, thought this smell was the cause of disease rather than a symptom of unsanitary conditions. They would try to combat it with perfumes, with vinegar washing, with anything except proper cleaning and hygiene. Windows might be open to air outwards, but the fundamental sources of contamination remained untouched. Water supplies in hospitals were often contaminated. Cholera outbreaks could be traced to hospital water sources. Typhoid spread through inadequate sewage systems. Even when hospitals weren't actively infected, they remained dangerous simply because of their basic infrastructure. The Victorians were building grand hospital buildings, architectural statements of medical progress, but they were building them with contaminated water supplies, inadequate sewage disposal, and no understanding of how to prevent disease transmission within their walls. For the poor, hospital admission was often the only option for serious illness or injury. They couldn't afford private physicians or home care. So they came to hospitals knowing the risks, hoping that perhaps they would be lucky, that perhaps they would be among the survivors. Some were, most weren't. The hospitals took them in, treated them with the best knowledge available, and buried them when treatment failed, which it usually did. For the middle class and wealthy, hospitals were increasingly seen as places to avoid. These classes could afford physicians who would visit their homes, could pay for private nursing care, could convalesce in their own beds, surrounded by family. Unless absolutely necessary, unless surgery was unavoidable, they stayed away from hospitals. They knew, even if they didn't understand the mechanisms, that hospitals were dangerous. The statistics, though not widely published, were whispered about. Everyone knew someone who had gone to hospital and never returned. Florence Nightingale's work during the Crimean War in the 1850s highlighted just how deadly hospital conditions were. She found British soldiers dying not primarily from their wounds, but from infections contracted in military hospitals. By implementing basic hygiene measures, proper ventilation, clean water, and systematic nursing care, she reduced mortality dramatically. Her success showed that hospital deaths were preventable, that with proper care, these institutions could actually help rather than harm. But even her example took decades to transform civilian hospital practice. The institutional inertia, the professional resistance to change, the sheer weight of tradition kept hospitals dangerous well into the late Victorian period. Joseph Lister's introduction of antiseptic surgery in the 1860s began to change the equation. By treating wounds and instruments with carbolic acid, by understanding that microorganisms cause infection and could be killed or excluded, Lister reduced surgical mortality dramatically. His wards at the Glasgow Royal Infirmary saw death rates drop from the horrific norms to much more acceptable levels. But even his clear success met fierce resistance from colleagues who couldn't accept that their traditional methods were killing patients. The transition from antiseptic to aseptic technique, from killing germs to preventing their presence, came slowly. By the 1890s, hospitals were beginning to implement sterilization, to clean instruments properly, to require hand washing, to adopt white coats that showed dirt instead of dark coats that hid blood. Surgical mortality began to drop. Hospital infections became less common. But this came near the end of the Victorian era, after decades of unnecessary death, after countless patients had died from infections that proper hygiene would have prevented. Looking back at Victorian hospitals, what strikes most powerfully is the gap between intention and outcome. These institutions were built to heal, staffed with people who had devoted their lives to medicine, funded with charitable donations and public money. Everyone involved believed they were doing good, believed they were providing the best care possible. And yet, they were killing patients at rates that would be considered criminal today. The confidence with which they operated, the certainty that their methods were correct, the pride they took in their institutions, all of it masked a fundamental failure. They were doing more harm than good, and they couldn't see it because they were too sure of their own knowledge to question, to observe, to admit that they were wrong. Tonight, as you drift toward sleep, consider those Victorian hospital wards packed with dying patients, attended by confident physicians, administered by dedicated nurses, all of them part of a system that killed efficiently while believing it healed. Consider how certainty can be lethal, how tradition can perpetuate harm, how the very institutions we build to help can become engines of destruction when they lose the ability to question, to learn, to change. Beyond the hospitals and operating theaters, beyond even the deadly practice of bloodletting and mercury poisoning, lay an entire pharmaceutical landscape that was equally dangerous. Victorian pharmacies and medicine cabinets were stocked with substances that today we recognize as poisons, addictive drugs, and dangerous compounds. And they were sold freely, prescribed routinely, and consumed eagerly by people desperate for relief from the illnesses that plagued them. Opium was everywhere. Laudanum, a tincture of opium and alcohol, was sold over the counter at every pharmacy and many general stores. It was marketed for everything from coughs and colds to diarrhea and insomnia. Mothers gave it to crying babies. Workers took it for aches and pains. The elderly used it for chronic conditions. The formula was simple: 10% opium, 90% alcohol, plus sometimes sugar or other flavoring. A few drops in water or tea, and within minutes the drug would take effect, bringing relief, calm, and eventually addiction. For children, there were special preparations. Godfrey's cordial, also called mother's friend, was a mixture of opium, water, and treacle, molasses. It was given to infants and children to quiet them, to help them sleep, to soothe teething pain or colic. The opiate content was often unlabeled or vague. Dosing was entirely at the caregiver's discretion, and the results were predictably tragic. Babies would become lethargic, stop feeding, slip into stupor, and sometimes die from respiratory depression. But the product remained popular because it worked, in the sense that it did quiet children. That it was essentially poisoning them seemed not to register or not to matter when weighed against the immediate relief it provided. Mrs. Winslow's soothing syrup was another popular children's remedy, containing morphine, a derivative of opium. It was marketed directly to mothers for teething babies, with advertisements showing peaceful infants and grateful parents. What they didn't show were the babies who died from overdose, the children who became addicted, the long-term effects of giving opiates to developing brains and bodies. The product was sold for decades before regulation finally required disclosure of its opiate content. For adults, the variety of opiate-containing products was astonishing. Ayer's Cherry Pectoral, a cough suppressant, combined alcohol and opium with a cherry flavoring. The label showed angelic children frolicking, suggesting health and innocence, while the contents could easily addict and poison. Dr. J. Collis Brown's chlorodyne claimed to cure coughs, colds, colic, spasms, bowel complaints, stomach aches, and sleeplessness. Its ingredients included morphine, chloral hydrate, a sedative, and cannabis. It was a powerful cocktail of psychoactive substances marketed as safe and appropriate for common ailments. Cocaine was similarly popular and equally unregulated. Coca leaves, from which cocaine is derived, were advertised as a nerve and muscle tonic. Products containing cocaine claimed to appease hunger and thirst and relieve sickness. Coca-Cola, in its original formulation, contained cocaine, though in relatively small amounts. The drug was seen as harmless, even beneficial, a stimulant that could help workers be more productive, help athletes perform better, help anyone who needed energy and focus. The addictive potential, the cardiovascular dangers, the psychological effects, all these were ignored or unknown. One particularly disturbing product was cocaine toothache drops, marketed to children. The label would show happy children, and the text would promise instant relief from dental pain. And it delivered, because cocaine is indeed an effective local anesthetic. But it was also creating addicted children, damaging developing hearts and brains, and normalizing drug use in the youngest and most vulnerable population. Patent medicines were a massive industry. These were proprietary formulations, their ingredients often secret or vaguely described, marketed directly to the public with extravagant claims. They promised to cure everything from consumption to cancer, from baldness to infertility. Most were some combination of alcohol, opiates, and other active ingredients, often in dangerous concentrations. They were bought by people who couldn't afford regular physician care, by those with chronic conditions who had tried everything else, by anyone desperate enough to believe the advertising. The lack of regulation was nearly complete until the late Victorian period. There were no requirements to list ingredients, no standards for purity or dosing, no testing for safety or efficacy. Anyone could mix chemicals in their back room and sell the result as medicine. If customers died, that was their problem. If they became addicted, that was their problem. The marketplace was essentially unregulated, driven entirely by what sold rather than what worked or what was safe. Arsenic found its way into numerous products. It was used in cosmetics to give skin a pale, fashionable glow. It was marketed as a tonic, supposedly stimulating the body. Small doses were thought to be harmless or even beneficial. The reality was that arsenic is a poison, and even small doses accumulate in the body over time. Chronic arsenic exposure led to symptoms including vomiting, diarrhea, skin lesions, peripheral neuropathy, and eventually organ failure. Some patients suffered slow, painful deaths without realizing their beauty regimen or health tonic was killing them. Lead was another common ingredient. Lead acetate, known as sugar of lead because of its sweet taste, was used as a sweetener in wines and medicines. It was also used in cosmetics and hair dyes. Lead poisoning caused abdominal pain, cognitive decline, anemia, and kidney damage. The neurological effects were particularly insidious, with patients experiencing personality changes, decreased intelligence, and motor dysfunction. Children were especially vulnerable, with lead exposure causing developmental delays and permanent cognitive impairment. Antimony, another toxic metal, found favor as a medicinal agent. Tartar emetic, antimony potassium tartrate, was used to induce vomiting, part of the heroic medicine approach. It was also prescribed for various fevers and infections. The poet and writer Oliver Goldsmith died in 1774 after taking St. James's fever powder, which contained antimony. The substance is toxic, causing severe gastrointestinal distress, liver and kidney damage, and in high doses, death. Even more bizarre treatments existed. Mummia, originally a natural bitumen but later made from actual ground mummified remains, was sold as medicine. People consumed powdered mummies believing it would cure various ailments. The practice was so popular that it created a market for mummies, leading to grave robbing in Egypt. What they were actually consuming was decayed human tissue, preserved with various chemicals, ground into powder. The therapeutic value was zero. The disgust factor was immense. Unicorn horn, actually narwhal tusk or rhinoceros horn, was sold at exorbitant prices for its supposed medicinal and protective properties. Queen Mary of Scotland reportedly used unicorn horn to protect against poisoning. It did nothing, of course, but the belief in its power was so strong that people would pay fortunes for what was essentially keratin, the same substance as fingernails. Tobacco was prescribed for respiratory ailments. Asthma cigarettes, containing tobacco sometimes mixed with herbs like belladonna, were marketed as treatments for breathing difficulties. The logic was that the smoke would open up airways. In reality, smoking tobacco damages lungs and exacerbates respiratory conditions. But the products remained popular because they did provide some immediate bronchodilation, while the long-term damage accumulated unseen. Alcohol was everywhere in Victorian medicine. Beyond being the solvent in many tinctures and tonics, it was prescribed directly as treatment. Brandy was considered a stimulant and restorative. Wine was thought to strengthen the blood. Beer was believed to aid digestion and improve complexion. Medical journals would seriously debate the therapeutic merits of different types of alcohol. The reality was that while alcohol might provide temporary symptom relief or psychological comfort, it was treating nothing and potentially creating addiction. The most tragic aspect of Victorian pharmaceutical practice was that it affected everyone but harmed the most vulnerable most severely. Children received dangerous drugs for minor ailments. The poor, who couldn't afford physician consultations, self-medicated with toxic patent medicines. Women were prescribed addictive substances for hysteria and other conditions that often reflected social problems rather than medical ones. The elderly, with multiple chronic conditions, would accumulate a pharmacopoeia of dangerous drugs. Addiction was common but poorly understood. People who had been taking opiate-containing medications for years would find themselves unable to stop without severe withdrawal symptoms. But rather than recognizing this as drug dependence, it was often seen as evidence of the underlying condition requiring continued treatment. So the prescriptions continued, the addiction deepened, and patients became trapped in cycles of dependence that could last lifetimes. The industry had little incentive to change. Patent medicines were hugely profitable. Manufacturers could make fantastic claims, charge high prices, and face no consequences if the products failed to work or actively harmed users. It wasn't until the late Victorian period and early 20th century that regulation began to emerge, requiring disclosure of ingredients, prohibiting fraudulent claims, and restricting access to the most dangerous substances. Looking at the Victorian medicine cabinet, what's striking is the sheer creativity deployed in finding new ways to poison people. Every toxic substance discovered was tested as medicine. Every psychoactive compound was marketed as therapeutic, and people consumed them eagerly, desperately hoping for relief from the genuine suffering that Victorian life often entailed. The tragedy was that the relief was temporary at best, and the consequences often permanent. The pharmacy that should have been a source of healing became another vector of harm in an era when medicine killed more reliably than it cured. Not content with mercury, bloodletting, filthy surgery, and poisonous pharmaceuticals, Victorian medicine found numerous other ways to harm patients in the name of healing. These treatments ranged from the merely useless to the actively deadly, each justified by medical theory of the time, each administered with confidence by practitioners who believed they were helping. Blistering was a common treatment that involved deliberately damaging skin to create fluid-filled blisters. The method was simple. Apply a substance like cantharides, Spanish fly, a powder made from crushed blister beetles, to the skin. The cantharidin would cause severe irritation, raising large blisters filled with fluid. The theory was that this drew badness out of the body, similar to the logic behind bloodletting. Patients would have blisters raised on their backs, chests, or wherever the illness was thought to be located. The pain was significant, the risk of infection high, and the therapeutic benefit non-existent. But the dramatic visible effect convinced both practitioners and patients that something was being done. Plasters were similar, consisting of wax mixed with various substances spread on leather and applied to the skin. Ingredients might include lead, opium, frankincense, or other materials thought to have therapeutic properties. These would be worn for extended periods, causing skin irritation and potentially exposing patients to toxic substances. Lead plasters were particularly dangerous, as lead could be absorbed through the skin, causing chronic poisoning. But the tradition persisted, handed down through generations of medical practice. Purging. involved administering powerful laxatives to induce violent diarrhea. The theory, again rooted in humoral medicine and heroic practice, was that evacuating the bowels would remove disease from the body. Substances like calomel, mercury, senna, and other purgatives would be given in large doses. The result was severe cramping, dehydration, electrolyte imbalances, and sometimes death. Patients who were already weakened by illness would be further weakened by aggressive purging, their bodies depleted of fluids and nutrients precisely when they most needed strength. Emetics induced vomiting through similar logic. Ipecac, antimony, and other substances would be administered to cause violent, repeated vomiting. The theory was that this expelled disease, that whatever was making the patient ill would be vomited out. The reality was dehydration, esophageal damage, aspiration risk, and exhaustion. Patients who were already weakened by illness would be further weakened by aggressive purging, their bodies depleted of fluids and nutrients precisely when they most needed strength. Emetics induced vomiting through similar logic. Ipecac, antimony, and other substances would be administered to cause violent, repeated vomiting. The theory was that this expelled disease, that whatever was making the patient ill would be vomited out. The reality was dehydration, esophageal damage, aspiration risk, and exhaustion. Combined with purging and bloodletting, as it often was in heroic medicine, this triple assault on the body often proved fatal. Cupping, mentioned earlier in connection with bloodletting, had dry and wet variations. Dry cupping involved applying heated cups to the skin, creating suction that drew blood to the surface and left dramatic circular bruises. The marks were considered evidence of successful treatment. Wet cupping added scarification, small cuts made before applying the cups so that blood would pool into them. The practice continued well into the Victorian era, popular among patients who found the dramatic marks reassuring evidence that treatment was occurring. Sweating treatments aimed to induce profuse perspiration. Patients might be wrapped in blankets and placed near intense heat, given diaphoretic medications, or subjected to vapor baths. The theory was that disease could be sweated out of the body. The reality was extreme discomfort, dehydration, and sometimes heat stroke. For patients with fever, forcing additional sweating was particularly dangerous, potentially pushing already elevated body temperatures to deadly levels. Electric shock treatments emerged as Victorian fascination with electricity grew. Various electrical devices were marketed for therapeutic purposes, delivering shocks to treat everything from paralysis to melancholy. While later, carefully controlled electroconvulsive therapy would find legitimate medical applications, Victorian electrical treatments were largely unregulated, with voltages and applications determined by practitioners with no understanding of neurology or electrical safety. Some patients were injured or killed by excessive electrical current. Bleeding patients wasn't limited to venesection and leeches. Scarification involved making multiple small cuts in the skin to release blood, or bad humors. The practice was particularly applied to areas of inflammation or swelling. The cuts could become infected. The blood loss could be significant if many scarifications were performed, and the therapeutic benefit was zero. Cauterization, burning tissue with hot iron or caustic chemicals, was used to treat various conditions. The theory was that burning would destroy disease and stimulate healing. For some conditions, like stopping severe bleeding, cauterization had limited utility. But it was often applied far more broadly, used to treat infections, tumors, and other conditions where burning tissue did nothing helpful and caused severe pain and scarring. Trepanation, drilling holes in the skull, had ancient origins, but continued into the Victorian era for certain conditions. Supposedly, it relieved pressure on the brain, treated mental illness, or addressed various neurological symptoms. In reality, opening the skull without sterile technique meant almost certain fatal infection. A few patients might have been helped if they genuinely had pressure from skull fractures or bleeding, but most underwent the procedure for conditions that drilling did nothing to address. Various gadgets and devices were sold for home treatment. Magnetic rings and belts claimed to restore health through magnetism. Electrical belts promised to cure impotence and other conditions. Radioactive products, after the discovery of radium, were marketed as health tonics. People drank radioactive water, used radioactive cosmetics, and even wore radioactive jewelry, not understanding that they were exposing themselves to cancer-causing radiation. Tobacco smoke enemas were used to treat various conditions, particularly for drowning victims. The idea was that pumping tobacco smoke into the rectum would stimulate breathing. Special devices were created for this purpose, and earnest practitioners would insert them and pump away, filling the unfortunate patient with smoke. The practice had no therapeutic value and added insult to injury for people already in distress. Bloodletting by non-traditional means continued in folk practice alongside professional medicine. Scarification, application of leeches to specific points, even deliberate creation of wounds to allow blood to drain, all persisted in communities that trusted traditional healers over licensed physicians. Sometimes this meant they avoided the worst of professional medicine's excesses. Other times, it meant they suffered under different but equally harmful practices. The use of toxic substances continued despite mounting evidence of harm. Strychnine was prescribed as a stimulant and tonic. Belladonna, containing atropine and other toxic alkaloids, was used for various purposes, despite its potential to cause delirium, hallucinations, and death. Digitalis, from foxglove plants, was prescribed for heart conditions, which was actually appropriate. But dosing was imprecise, and overdoses were common, causing dangerous cardiac arrhythmias. Mineral waters and spa treatments were popular, sometimes helpful, but often mixed with questionable practices. Some springs did contain minerals that might have modest therapeutic effects, and the rest and fresh air of spa resorts likely helped some patients. But various dubious treatments would be layered on top, from special diets to electrical baths to the consumption of vast quantities of mineral water that could cause imbalances if overdone. The sheer variety of harmful treatments reflects a medical system operating without scientific rigor. If something created dramatic effects, if it fit existing theory, if tradition supported it, it would be tried. Patient outcomes took a back seat to professional tradition, theoretical consistency, and the imperative to do something, anything, rather than admit that often the best treatment was simply supportive care and time. These miscellaneous treatments, added to the major killers like mercury poisoning, aggressive bloodletting, and surgical infection, created a comprehensive system of medical harm. A patient might survive the disease only to be killed by the treatment. Or they might suffer through multiple treatments, each adding its own damage, until their bodies simply couldn't cope anymore. Victorian medicine offered many paths to harm, numerous ways for well-meaning healers to become agents of death. The irony is that through all of this, some patients survived and even thrived. The human body is remarkably resilient, capable of healing despite, rather than because of Victorian medical intervention. Those who survived did so largely through their own constitutions, through the nursing care that provided basic comfort and nutrition, through luck. The treatments they received often did nothing or made things worse. But practitioners saw the survivors and took credit, interpreting recovery as proof of their method's efficacy, rather than recognizing it as evidence of human resilience in the face of medical assault. Finally, late in the Victorian era, change began to emerge. Not suddenly, not uniformly, but gradually, the foundations of modern medicine started to replace the deadly certainties of tradition. The revolution came from multiple directions: laboratory science, careful observation, statistical analysis, and the courage of individuals willing to challenge established practice, even at cost to their own careers and reputations. Louis Pasteur's work in France provided the crucial breakthrough in understanding disease. Through careful experiments, Pasteur demonstrated that microorganisms caused fermentation and spoilage. He proved that these organisms didn't spontaneously generate, but came from existing organisms. He developed methods to kill or exclude them through heat treatment and careful technique. His germ theory of disease provided a framework for understanding infection that made sense of observations that miasma theory couldn't explain. But knowing that germs existed didn't immediately change medical practice. The medical establishment, particularly in Britain, was skeptical. Germs were invisible. They seemed far-fetched. And accepting them meant accepting that traditional theories were wrong, that the practices taught for generations were based on false premises. Professional pride and institutional inertia resisted this new understanding, even as evidence accumulated. Joseph Lister, a Scottish surgeon working in Glasgow, read Pasteur's work and made the connection to surgical infections. If microorganisms caused fermentation, perhaps they also caused the suppuration and gangrene that killed so many surgical patients. If so, then preventing or killing these organisms would prevent infection. It was a logical leap that most of Lister's contemporaries wouldn't make, but Lister had both the insight and the courage to test it. He began using carbolic acid, a coal tar derivative with antiseptic properties, to treat surgical wounds. He would spray it on instruments, on wounds, on surgical fields. He dressed wounds with carbolic-soaked bandages. He advocated for cleaning everything that would contact the wound. and his results were dramatic. In his wards, surgical mortality dropped from the horrific normal rates to levels that seemed almost miraculous. Patients who should have died from infection survived. Lister published his findings in 1867 in the medical journal The Lancet. He presented careful statistics, documented cases, and a theoretical framework explaining why antiseptic technique worked. The evidence was clear, the improvement was undeniable, and the medical establishment largely rejected it. Why? Multiple reasons. First, Lister's technique was complicated and annoying. Carbolic acid smelled bad. It irritated skin. It required extra steps, extra time, extra effort. Surgeons who had practiced for decades weren't eager to adopt tedious new procedures. Second, it implied that they had been causing infections, that their traditional practices had been killing patients. This was professionally insulting and personally uncomfortable. Better to reject the new idea than accept such implications. Third, some early adopters applied the technique incorrectly and didn't see improvements, leading to claims that it didn't work. Fourth, carbolic acid itself could be toxic if used in excessive concentrations, creating new problems even as it solved others. And finally, the theoretical basis, germ theory, remained controversial. Many physicians simply didn't believe in germs, couldn't accept that invisible organisms were the culprits. But Lister persisted. He refined his techniques, reduced carbolic concentrations to safer levels, published more cases, and trained students in antiseptic methods. Gradually, a few surgeons adopted his approach and saw similar improvements. Word spread, statistics accumulated. By the 1870s and 80s, antiseptic surgery was gaining acceptance, though pockets of resistance remained even into the 1890s. The transition from antiseptic to aseptic technique marked another evolution. Antiseptic meant killing germs with chemicals like carbolic acid. Aseptic meant preventing germ presence through cleanliness and sterilization. This approach used heat to sterilize instruments, thorough washing with soap and water, clean surgical gowns and drapes, isolation of surgical spaces from contaminated environments. It was less toxic than carbolic acid and more reliable. By the 1890s, hospitals were installing autoclaves to steam sterilize instruments. Surgeons began wearing white gowns that showed dirt and blood, replacing the black blood-crusted coats they'd worn with pride. Operating rooms were redesigned with smooth, washable surfaces. Nurses received training in maintaining sterile technique. The change was comprehensive, touching every aspect of surgical practice. Hand washing, that simple intervention Semmelweis had advocated decades earlier, finally became standard. Surgeons would scrub their hands thoroughly before operations. Gloves, originally introduced to protect surgeons' hands from harsh antiseptics, turned out to provide a barrier preventing contamination from hands to patient. Masks prevented respiratory droplets from contaminating surgical fields. The entire practice of surgery was transformed. Similar advances occurred in understanding infectious disease more broadly. Robert Koch in Germany identified specific bacteria causing specific diseases, including tuberculosis and cholera. This work provided concrete evidence for germ theory, showing actual organisms under microscopes, growing them in cultures, proving they caused disease by inoculating healthy animals. The evidence became overwhelming. Understanding how disease spread led to public health improvements. Cities installed proper sewage systems, separated clean water supplies from waste, implemented sanitation measures. These changes reduced deaths from cholera, typhoid, and other waterborne diseases far more effectively than any medical treatment had. The greatest improvements in Victorian health came not from doctors, but from engineers and public health officials who addressed basic sanitation. Anesthesia, that mixed blessing that had initially increased surgical mortality by enabling longer, more invasive procedures, was refined. Practitioners learned to monitor patients more carefully, to use appropriate doses, to manage airways. Combined with antiseptic and then aseptic technique, anesthesia finally fulfilled its promise of making surgery less traumatic and more survivable. Obstetrics began to change as well, though more slowly. The all-male physician-dominated field resisted the idea that hand-washing mattered, resisted the reforms that midwives had been advocating. But eventually, as maternal mortality statistics became undeniable, as public pressure grew, standards improved. Physicians attending births began washing their hands, began using antiseptic techniques, began recognizing that their own practices had been killing mothers. Pharmacology started to become more scientific. Rather than prescribing based on theoretical humoral balance, physicians began to consider actual mechanisms of action, actual effects on the body. Harmful substances like mercury were gradually phased out as safer alternatives emerged. Regulation of medications began, slowly at first, requiring disclosure of ingredients, restricting the most dangerous substances, eventually establishing safety and efficacy requirements. By the end of Victoria's reign in 1901, medicine was transformed from what it had been at her coronation. Not completely, not perfectly, but substantially. Germ theory was accepted. Antiseptic and aseptic techniques were standard. Public health measures had reduced epidemic disease. Dangerous treatments like aggressive bloodletting and mercury poisoning were declining. Medicine was beginning to do more good than harm. But this transformation came too late for hundreds of thousands who died under the old system. It came after decades of resistance from the very professionals who should have embraced it most quickly. It came through the work of pioneers who were often persecuted, ridiculed, and dismissed by their colleagues. And it came only because accumulating evidence eventually became impossible to ignore, because younger physicians trained in new methods replaced older practitioners, because the sheer weight of mortality statistics finally overwhelmed professional pride and traditional practice. The story of Victorian medicine's transformation is ultimately about the difficulty of change, about how hard it is to abandon cherished beliefs even in the face of clear evidence, about how institutional and professional structures can perpetuate harm even when better ways are known. It's a story that should humble anyone in medicine or science, a reminder that today's certainties may be tomorrow's embarrassments, that the confidence with which we practice doesn't guarantee we're right. The bare statistics of Victorian medicine tell a grim story, but the human cost behind those numbers is what truly reveals the tragedy. These weren't just percentages dying in hospitals or mortality rates in surgical wards. These were individuals, each with their own story, each suffering under treatments that were supposed to heal them. Some of their stories survived, documented in diaries, medical case records, and autobiographies. They serve as testament to the real consequences of medical hubris. Elizabeth Story's story has already been mentioned, but it bears repeating in fuller detail. She was an ordinary Scottish girl, not wealthy, not privileged, just a child who fell ill with something minor. Her doctor prescribed calomel, that ubiquitous mercury preparation. But he didn't stop after a few doses. He continued the treatment for an extended period, pouring mercury into a child's body day after day. The poisoning was severe. Her hands and feet swelled grotesquely, became icy cold, turned bright red. Her skin began peeling off like the skin of tomatoes plunged into boiling water. She lost weight rapidly as her body tried desperately to cope with the poison flooding her system. The itching was so intense that she clawed at herself constantly, tearing raw skin open, unable to stop despite the pain. Her fever spiked to 102 degrees. She became, in her mother's words, insane. Not metaphorically, but actually mentally deranged from the neurotoxic effects of mercury. She sat in her cot, banging her head with her hands, pulling out her hair in clumps, screaming without words, scratching viciously at anyone who came close enough to try to help her. This was a child transformed by medicine into a creature of pain and madness. And this continued for months. Elizabeth survived, but her life was destroyed. She remained disabled, her body permanently damaged by the mercury. She couldn't work normally, couldn't live normally. The minor childhood illness that prompted treatment was nothing compared to what the treatment did to her. In her 1859 autobiography, she detailed her suffering not as a medical curiosity, but as a warning, a testament to what medicine could do in the name of healing. Carlton Bergen, the Civil War soldier mentioned earlier, tells a similar story. He survived the battlefield, survived enemy fire, only to be destroyed by his own army's doctors. A simple infection, the kind that today would be cured with antibiotics and rest, prompted treatment with calomel. The mercury poisoning left his face permanently disfigured, holes where his cheeks should have been, exposed bone where soft tissue had rotted away. He returned from war a monster, not because of enemy action, but because of medical treatment. For the rest of his life, he bore the physical evidence of what Victorian medicine could do. The case documented in the Journal of the American Medical Association in 1910 tells of a 35-year-old woman who used mercury chloride as a vaginal douche, likely for some gynecological complaint or venereal disease treatment. The mercury absorbed through her vaginal tissue, rapidly reaching toxic levels in her bloodstream. Within 4 days, she was vomiting persistently. By the time she sought help, it was too late. She vomited blood. Her consciousness deteriorated into stupor. Her kidneys failed, unable to filter the poison from her blood. She died within a week, her body destroyed by a treatment that was supposed to cure her. The physician who documented her case wrote that this should serve as a warning, but similar cases continued for decades after. Julia Sullivan, the woman whose case Joseph Lister handled in the 1860s, represents both the old danger and the new hope. Brought in by police after being stabbed by her drunken husband, she should have died. The conventional treatment would have been cauterization with a red-hot iron, burning the wound to prevent infection. This was excruciating and often ineffective. Lister instead cleaned the wound, carefully replaced her protruding intestines, and sewed her up using antiseptic technique. She survived, not despite the treatment, but because of it. Her case demonstrated that medicine could help when it abandoned traditional harmful practices for evidence-based approaches. The unnamed women who died from puerperal fever in Semmelweis's Vienna clinic before he instituted hand-washing represent hundreds more. They came to the hospital in labor, excited and nervous about bringing new life into the world. They delivered their babies successfully. Then, within days, they developed fever. Their wounds became infected. The infection spread through their bodies. They became delirious, burning with fever, in agony. And they died, often within a week of giving birth, leaving behind newborns and grieving families. All because the doctors attending them didn't wash their hands, carrying death from the autopsy room to the delivery ward on their educated, unwashed fingers. The children who died from Godfrey's cordial and similar opiate-containing remedies left no detailed records, but we can imagine their stories. A baby crying from colic or teething pain. Exhausted parents wanting relief for themselves and their child, administering the popular remedy. The baby quieting, seeming to sleep peacefully. But that peace was drug-induced sedation, and if the dose was too high, if it was given too frequently, the baby's breathing would slow, would stop. Sudden infant death, attributed to natural causes, but actually drug overdose. How many babies died this way? Records don't tell us. But given the popularity of these products and their opiate content, the number must have been substantial. Abraham Lincoln's story illustrates how even the powerful and prominent weren't spared. Before his presidency, he took blue mass pills regularly for melancholy and other complaints. The mercury in those pills likely contributed to his reported symptoms. Insomnia that left him exhausted, tremors in his hands, sudden rage attacks that were out of character. These are textbook signs of mercury toxicity. He stopped taking the pills shortly after becoming president, apparently recognizing that they made him cross. One wonders how American history might have been different if Lincoln had been functioning without the neurotoxic effects of mercury during his early political career. Edgar Allan Poe's death in 1849 remains mysterious, but we know he was treated with calomel shortly before. Found delirious on the streets of Baltimore, calling out a name no one recognized, he died in the hospital a few days later. The delirium, the incoherent speech, the rapid decline, all are consistent with mercury poisoning compounding whatever else was wrong. We'll never know for certain what killed Poe, but we know that the medicine he received didn't help and might have hastened his end. The poor of Victorian Britain, those who lived in slums and worked brutal hours in factories, faced the worst of all medical worlds. They couldn't afford regular physician care, so they self-medicated with patent medicines from pharmacies or street vendors. These were often the most dangerous products, the ones with the highest alcohol and opiate content, the most toxic additives. When they did see physicians, often in charity wards, they received the most aggressive treatments. They were the teaching cases, the bodies on which medical students learned, the subjects of experimental approaches. A factory worker with a chronic cough might spend his limited earnings on opiate-laden cough syrup, becoming addicted while the underlying condition, perhaps tuberculosis, progressed untreated. A seamstress with lead poisoning from working with lead-based materials might seek treatment and receive bloodletting that weakened her further. A laborer injured at work might undergo amputation in a filthy hospital ward and die of infection that was entirely preventable. The poor suffered most because they had the least ability to avoid harmful treatments, the least power to demand better care, the least buffer against medical harm. Children in workhouses and orphanages were particularly vulnerable. They might be given patent medicines to keep them quiet, sedated with opiates so they'd be less trouble to caretakers. They might be subjected to treatments that adult patients could refuse, but powerless children could not. Medical experiments were sometimes performed on institutionalized children, testing new treatments or theories on those who had no voice, no advocates, no way to say no. Carlton Bergen, the Civil War soldier mentioned earlier, tells a similar story. He survived the battlefield, survived enemy fire, only to be destroyed by his own army's doctors. A simple infection, the kind that today would be cured with antibiotics and rest, prompted treatment with calomel. The mercury poisoning left his face permanently disfigured, holes where his cheeks should have been, exposed bone where soft tissue had rotted away. He returned from war a monster, not because of enemy action, but because of medical treatment. For the rest of his life, he bore the physical evidence of what Victorian medicine could do. The case documented in the Journal of the American Medical Association in 1910 tells of a 35-year-old woman who used mercury chloride as a vaginal douche, likely for some gynecological complaint or venereal disease treatment. The mercury absorbed through her vaginal tissue, rapidly reaching toxic levels in her bloodstream. Within 4 days, she was vomiting persistently. By the time she sought help, it was too late. She vomited blood. Her consciousness deteriorated into stupor. Her kidneys failed, unable to filter the poison from her blood. She died within a week, her body destroyed by a treatment that was supposed to cure her. The physician who documented her case wrote that this should serve as a warning, but similar cases continued for decades after. Julia Sullivan, the woman whose case Joseph Lister handled in the 1860s, represents both the old danger and the new hope. Brought in by police after being stabbed by her drunken husband, she should have died. The conventional treatment would have been cauterization with a red-hot iron, burning the wound to prevent infection. This was excruciating and often ineffective. Lister instead cleaned the wound, carefully replaced her protruding intestines, and sewed her up using antiseptic technique. She survived, not despite the treatment, but because of it. Her case demonstrated that medicine could help when it abandoned traditional harmful practices for evidence-based approaches. The unnamed women who died from puerperal fever in Semmelweis's Vienna clinic before he instituted hand-washing represent hundreds more. They came to the hospital in labor, excited and nervous about bringing new life into the world. They delivered their babies successfully. Then, within days, they developed fever. Their wounds became infected. The infection spread through their bodies. They became delirious, burning with fever, in agony. And they died, often within a week of giving birth, leaving behind newborns and grieving families. All because the doctors attending them didn't wash their hands, carrying death from the autopsy room to the delivery ward on their educated, unwashed fingers. The children who died from Godfrey's cordial and similar opiate-containing remedies left no detailed records, but we can imagine their stories. A baby crying from colic or teething pain. Exhausted parents wanting relief for themselves and their child, administering the popular remedy. The baby quieting, seeming to sleep peacefully. But that peace was drug-induced sedation, and if the dose was too high, if it was given too frequently, the baby's breathing would slow, would stop. Sudden infant death, attributed to natural causes, but actually drug overdose. How many babies died this way? Records don't tell us. But given the popularity of these products and their opiate content, the number must have been substantial. Abraham Lincoln's story illustrates how even the powerful and prominent weren't spared. Before his presidency, he took blue mass pills regularly for melancholy and other complaints. The mercury in those pills likely contributed to his reported symptoms. Insomnia that left him exhausted, tremors in his hands, sudden rage attacks that were out of character. These are textbook signs of mercury toxicity. He stopped taking the pills shortly after becoming president, apparently recognizing that they made him cross. One wonders how American history might have been different if Lincoln had been functioning without the neurotoxic effects of mercury during his early political career. Edgar Allan Poe's death in 1849 remains mysterious, but we know he was treated with calomel shortly before. Found delirious on the streets of Baltimore, calling out a name no one recognized, he died in the hospital a few days later. The delirium, the incoherent speech, the rapid decline, all are consistent with mercury poisoning compounding whatever else was wrong. We'll never know for certain what killed Poe, but we know that the medicine he received didn't help and might have hastened his end. The poor of Victorian Britain, those who lived in slums and worked brutal hours in factories, faced the worst of all medical worlds. They couldn't afford regular physician care, so they self-medicated with patent medicines from pharmacies or street vendors. These were often the most dangerous products, the ones with the highest alcohol and opiate content, the most toxic additives. When they did see physicians, often in charity wards, they received the most aggressive treatments. They were the teaching cases, the bodies on which medical students learned, the subjects of experimental approaches. A factory worker with a chronic cough might spend his limited earnings on opiate-laden cough syrup, becoming addicted while the underlying condition, perhaps tuberculosis, progressed untreated. A seamstress with lead poisoning from working with lead-based materials might seek treatment and receive bloodletting that weakened her further. A laborer injured at work might undergo amputation in a filthy hospital ward and die of infection that was entirely preventable. The poor suffered most because they had the least ability to avoid harmful treatments, the least power to demand better care, the least buffer against medical harm. Children in workhouses and orphanages were particularly vulnerable. They might be given patent medicines to keep them quiet, sedated with opiates so they'd be less trouble to caretakers. They might be subjected to treatments that adult patients could refuse, but powerless children could not. Medical experiments were sometimes performed on institutionalized children, testing new treatments or theories on those who had no voice, no advocates, no way to say no. The 41 medical students who died from infections at St. Bartholomew's Hospital represent the aspiring physicians who were killed by the very system they were learning to practice. Young men who had devoted themselves to medicine, who wanted to heal, who were willing to work among the sick and dying, were themselves infected and killed. Their deaths should have been a wake-up call, clear evidence that something was fundamentally wrong with hospital practice. But they were accepted as tragic but inevitable costs of medical education. Each of these stories represents countless others that weren't documented. For every case written up in medical journals, hundreds or thousands experienced similar fates unrecorded. For every famous figure whose medical travails are known, countless ordinary people suffered and died without anyone preserving their stories. The human cost of Victorian medicine extends beyond what any accounting can capture, beyond what any statistics can convey. What makes these stories particularly tragic is that the suffering was preventable. These weren't deaths from incurable diseases or unavoidable accidents. These were deaths and disabilities caused by treatments, by remedies, by the actions of physicians and pharmacists who believed they were helping. The road to medical harm was paved with good intentions, with confidence in traditional practices, with adherence to theoretical frameworks that were fundamentally wrong. As you drift toward sleep tonight, think about these individuals, these real people who suffered under Victorian medicine. They weren't statistics. They were human beings who sought help and received harm, who trusted their doctors and were betrayed by deadly certainty, who wanted healing and received poison instead. Their stories should humble us, should remind us that medical confidence without evidence can be lethal, that tradition without questioning can perpetuate harm across generations. The question remains, why did change take so long? If the evidence was there, if the suffering was obvious, if alternatives existed, why did Victorian medicine persist in its deadly practices for decades after better methods were known? The answer reveals uncomfortable truths about human nature, professional culture, and institutional resistance to change. Professional pride played perhaps the largest role. Physicians had invested years in training, had memorized ancient texts, had learned traditional practices from respected teachers. To admit that these practices were wrong meant admitting that their training had been inadequate or misleading, that their teachers had been mistaken, that their professional identity was built on flawed foundations. This was psychologically difficult to accept. It was easier to reject new ideas, to find reasons why evidence was flawed, to maintain existing practices even in the face of mounting deaths. Economic interests also mattered. Medicine was becoming increasingly professionalized and commercialized. Physicians charged substantial fees for elaborate treatments. Patent medicine manufacturers made fortunes from their products. Hospitals attracted donors by showcasing their impressive buildings and large caseloads. Admitting that simpler, cheaper approaches worked better would threaten these economic interests. A doctor who charged high fees for bloodletting, purging, and mercury administration had little incentive to acknowledge that rest and nursing care often worked better and cost much less. The hierarchical structure of medicine reinforced conservatism. Senior physicians who had the most invested in traditional practices controlled medical schools, professional societies, and hospital appointments. They determined what was taught, what was published, what was considered respectable practice. Young physicians who questioned established approaches risked their careers. Semmelweis was hounded from his position for suggesting doctors wash their hands. Others faced similar persecution for challenging accepted wisdom. The price of dissent was high, creating strong incentives to conform. The education system perpetuated outdated ideas. Medical schools taught from ancient texts, emphasized tradition, and rewarded students who memorized and recited rather than questioned and observed. Galen's writings, over 1,500 years old, were still considered authoritative. Humoral theory was still taught as fact. Students learned that bloodletting was essential, that mercury was therapeutic, that their training gave them authority beyond question. This educational approach created generations of physicians who entered practice already convinced of the correctness of harmful treatments. Lack of rigorous scientific method made it difficult to demonstrate which treatments worked. Without controlled trials, without statistical analysis, without systematic observation, anecdotal evidence dominated. A physician would see some patients recover after treatment and attribute the recovery to the treatment, ignoring the patients who died, or recognizing those deaths as inevitable rather than treatment-caused. Confirmation bias was rampant. Doctors saw what they expected to see, interpreted evidence in ways that supported existing beliefs, and dismissed contradictory observations. The slow spread of information also hindered change. Medical journals existed but circulated slowly. International communication was limited. A discovery in France might take years to reach British practitioners, and even longer to gain acceptance. Lister's work was published in the 1860s but didn't achieve wide acceptance until the 1880s or 90s. That's decades of unnecessary deaths while better methods were known but not adopted. Cultural factors played a role as well. Victorian society valued tradition, respected established institutions, and was suspicious of rapid change. The medical profession reflected these broader cultural values. There was also an element of macho in medicine. Heroic treatments that were aggressive and dramatic seemed more manly, more decisive than gentle approaches or admission that often the body healed itself. A physician who bled patients aggressively seemed more bold and skilled than one who advocated rest and nursing care. Specialization was limited, and the profession was relatively small and insular. Everyone knew everyone, or at least knew of them. Challenging a prominent physician wasn't just questioning an idea, but threatening a person, someone with whom you might have professional relationships, someone who could affect your career. This social dimension made intellectual challenge more personal and thus more difficult. Patients themselves sometimes resisted change. They had been taught to expect certain treatments. If a physician didn't bleed them or prescribe mercury, they might feel they weren't receiving proper care. They might seek another physician who would provide the traditional interventions they expected. This patient demand helped perpetuate harmful practices, even when some physicians wanted to abandon them. There was also genuine uncertainty about what worked. Some patients did recover after treatment. Some genuinely did benefit from certain interventions. Sorting out which treatments helped, which hurt, and which did nothing required careful observation and analysis that rarely occurred. The complexity of human illness, with its variable courses and multiple factors affecting outcomes, made it hard to draw clear conclusions without rigorous methodology. The absence of modern diagnostic tools meant physicians often didn't know exactly what disease they were treating. They relied on symptoms and theories rather than definitive diagnoses. This made it even harder to evaluate treatment effectiveness. Was this fever from infection, from inflammation, from mysterious humoral imbalance? Different theories might suggest different treatments, and without knowing the actual cause, there was no way to definitively say which approach was correct. Legal and regulatory structures were minimal. There were few consequences for harmful treatments. Doctors couldn't be sued successfully for following accepted practice, even if that practice killed patients. Patent medicine manufacturers faced no liability for false claims or dangerous products. The regulatory environment essentially allowed medical harm to continue unchecked. The gradual nature of change meant that improvements often occurred across generations rather than within them. Older physicians practiced until retirement or death, maintaining traditional methods. Younger physicians, trained in newer approaches, slowly replaced them. Full transformation required waiting for generational turnover, for the old guard to literally die off before new ideas could dominate. Institutional inertia was powerful. Hospitals had established routines, traditional practices, ways of doing things that had been refined over decades. Changing these required overcoming bureaucracy, convincing multiple stakeholders, retraining staff, often rebuilding infrastructure. The path of least resistance was to maintain existing practice even when change would benefit patients. All these factors combined to create a system remarkably resistant to change, where better knowledge existed but wasn't implemented, where evidence was ignored or disputed, where traditional harmful practices continued long after they should have been abandoned. The result was decades of unnecessary suffering, hundreds of thousands of preventable deaths, countless people harmed by the very medical system that promised to heal them. Understanding why change was so slow doesn't excuse it, But it does help explain the tragedy. It wasn't that everyone involved was malicious or incompetent. It was that human nature, professional structures, economic interests, educational systems, and cultural factors all aligned to perpetuate harm. Breaking through required exceptional individuals willing to risk everything. Required accumulating evidence so overwhelming it couldn't be ignored. Required younger generations willing to question their teachers. Required patients beginning to demand better. Change came, but it came slowly, and the cost was measured in corpses. As we reach the end of this journey through Victorian medicine's deadly halls, it's worth reflecting on what this history means, both for understanding the past and for considering the present and future of medicine. The Victorian era stands as a stark reminder that medical confidence can be lethal. The physicians who prescribed mercury, who drained blood in enormous quantities, who operated in filthy conditions, were not ignorant villagers practicing folk medicine. They were educated professionals, graduates of prestigious universities, members of respected institutions. They had access to the best knowledge of their time. And they killed patients with astonishing regularity, all while believing firmly that they were providing excellent care. This should humble us. Today's medical certainties may seem as solid and unquestionable as Victorian physicians' beliefs seemed to them. We have the advantage of germ theory, of antibiotics, of imaging technology, of clinical trials, and evidence-based practice. Our methods are vastly superior to those of the Victorian era. But are we immune to the same errors of overconfidence, of adherence to practice despite evidence, of resistance to change when change threatens professional interests? The history suggests not. Medical practice continues to evolve, continues to discover that practices once considered standard were actually harmful or useless. How many current treatments will future generations look back on with horror? What are we doing now with complete confidence that future physicians will recognize as harmful or misguided? The question isn't whether such practices exist, but which ones they are. The Victorian experience also highlights the importance of humility in medicine. The physicians who caused the most harm were often those most confident in their knowledge, most resistant to questioning, most certain that their training and tradition gave them absolute authority. The ones who helped patients were often those willing to observe carefully, to question accepted wisdom, to follow evidence even when it contradicted what they'd been taught. Semmelweis washing his hands despite mockery. Lister persisting with antiseptic technique despite resistance. These weren't the most prominent physicians of their era. They were outsiders, questioners, people willing to challenge the establishment. Their heroism wasn't in dramatic surgical feats, but in quiet observation, in careful analysis, in persistence despite opposition. They saved lives not through traditional knowledge, but through willingness to question it. The role of evidence-based practice emerges as crucial. Victorian medicine failed largely because it relied on theory, tradition, and anecdote rather than rigorous testing. When bloodletting was finally subjected to careful statistical analysis, when antiseptic surgery's results were documented and compared to traditional approaches, the truth became undeniable. Evidence, properly gathered and honestly analyzed, cuts through professional pride and traditional practice. The lesson is that medicine must remain committed to evidence over authority, to observation over theory, to outcomes over tradition. The transformation of Victorian medicine also demonstrates that progress is possible. By the end of Victoria's reign, medicine was fundamentally different and vastly superior to medicine at the beginning. Germ theory had replaced humoral theory. Antiseptic and aseptic technique had made surgery survivable. Public health measures had reduced epidemic disease. Dangerous treatments had been largely abandoned. The change was neither quick nor easy, but it occurred. Medicine can improve, can abandon harmful practices, can save rather than kill. But this requires constant vigilance, constant questioning, constant willingness to change when evidence demands it. For patients, the Victorian experience is both reassuring and cautionary. Reassuring because it shows how far medicine has come, how much safer modern care is compared to what previous generations endured. The fact that we can undergo surgery without expecting infection, that we can take medications without fear of mercury poisoning, that we can seek medical care without risking immediate death represents tremendous progress. But it's also cautionary because it reminds us that medical authority should be questioned, that patients have the right and responsibility to understand their care, that blind trust in physicians can. The economic and institutional lessons remain relevant. Victorian medicine's deadly practices persisted partly because they were profitable, because they supported professional interests, because institutions had invested in them. Today's medicine faces similar pressures. Expensive treatments may be promoted over cheaper alternatives. Procedures may be performed because they're reimbursable rather than because they're necessary. Pharmaceutical companies may market drugs aggressively despite modest benefits or significant harms. The profit motive hasn't disappeared from medicine, and its potential to promote harmful practices hasn't disappeared either. The importance of regulation also emerges clearly. Victorian medicine's worst excesses occurred in an essentially unregulated environment. Anyone could sell any substance as medicine. Physicians faced no meaningful accountability for outcomes. Hospitals operated without standards or oversight. The gradual introduction of regulation, of requirements for ingredient disclosure, of medical licensing, of hospital standards, all contributed to reducing harm. Modern regulatory systems, however imperfect, serve an essential function in protecting patients from the kinds of dangers Victorian patients faced. Education matters too. Medical education that emphasizes memorization over critical thinking, tradition over evidence, authority over questioning, perpetuates harm. The Victorian experience shows where that leads. Modern medical education has improved, with emphasis on scientific method, evidence-based practice, and continuous learning. But the fundamental question remains: are we teaching future physicians to question, to observe, to follow evidence even when it contradicts what they've learned? Or are we creating another generation of confident practitioners who will resist necessary change? The human stories we've explored remind us that behind every statistic is a person, that medical harm isn't abstract, but concrete, affecting real individuals with real lives. Elizabeth's story's disfigurement, Carlton Bergen's destroyed face, the mothers dying from puerperal fever, the children poisoned by teething powders. All of them were human beings who deserved better than what Victorian medicine gave them. This should inform how we think about medical errors and harms today. They're not just numbers in databases, but tragedies affecting patients and families. Perhaps the most important lesson is about the danger of certainty. Victorian medicine killed so efficiently, partly because its practitioners were so certain they were right, so confident in their knowledge, so unwilling to question or doubt. That certainty made them impervious to evidence, resistant to change, and ultimately responsible for enormous harm. Medicine requires confidence to make decisions, to act decisively in urgent situations. But that confidence must be balanced with humility, with recognition of uncertainty, with willingness to admit error and change course. As you finally drift into sleep, consider this. We live in an era when medicine helps far more than it harms, when seeking medical care usually improves rather than worsens outcomes, when the promise to heal is more often kept than broken. This is a tremendous achievement, built on the pain of countless Victorian patients who suffered under a system that claimed to heal while it killed. We owe them our gratitude and our commitment to do better, to learn from their suffering, to build a medical system that truly serves patients rather than tradition, professional pride, or economic interest. The Victorian era shows us where medicine came from, how deadly it was, how confidently it killed. Understanding this history doesn't diminish respect for medicine, but deepens it, making us appreciate how hard-won our current knowledge is, how important it is to maintain humility and openness to evidence, how crucial it is never to become so certain that we stop questioning. Sleep well, knowing that the horrors of Victorian medicine are behind us, but sleep also with the awareness that vigilance is required, that medicine's promise to heal must be constantly reaffirmed through evidence and humility, that the confidence that killed so many Victorians can return in new forms unless we remain committed to learning, questioning, and improving. If you found this journey through medical history's darker chapters helpful in drifting toward sleep, go ahead and like and subscribe to our channel. And tell us in the comments, where are you listening from, and has this changed how you think about modern medicine? Your support helps us continue exploring these peaceful historical topics. Sleep well, and remember, tomorrow you'll wake in an era when medicine mostly works, when treatments mostly help, when the healer's hands are mostly clean. That's progress worth appreciating.